colleagues. Welcome to the 5th Annual OncoAlert Colloquium, a comprehensive review of the year's top scientific advancements organized by Tumor Group. The colloquium is made possible thanks to our partners at the European Society of Gynecological Oncology, the European Society of Surgical Oncology, the Multidisciplinary Association of Supportive Care in Cancer, and the International Society of Geriatric Oncology. We're also grateful for the tremendous collaboration from the Advanced Prostate Cancer Consensus Conference, ABC Global Alliance in Breast Cancer, the Belgian Society of Medical Oncology, KidneyCan, the GARD Consortium, and our friends at GUcast. We would like to thank Pfizer and Roche for partly sponsoring this year's colloquium, and we would like to remind you that all presentations that you will see have been made independently by presenters with no industry influence on topics or content. The colloquium is divided into 7 days. Day 1, GU Oncology. Day 2, Lung Cancer and Supportive Care. Day 3, Breast Cancer. Day 4, GI Oncology. Day 5, Gynecological Cancers. Day 6, Hematology, Sarcoma, Lymphoma, and Geriatric Oncology. And Day 7, How I Treat Cancer When Facing Limited Resources. Today we start off with GU Oncology, and a pleasure to introduce today's speakers. Dr. Vincent Chu of Dana-Farber Cancer Institute, Dr. Petros Grivas of Fred Hutch Cancer Center, Dr. Silke Yillison of Advanced Prostate Cancer Consensus Conference, Drs. Declan Murphy and Renu Ipin of GUcast, Dr. Shan McBride of Memorial Sloan Kettering, Dr. Maria Jose Juan Fita and Dr. Elena Sevillano of the GARD Consortium, and we finish with the patient advocate perspective with Mr. Brian Lewis of KidneyCan. We hope you enjoy this first day of the colloquium, and now without further ado, Dr. Chu.
Hello, and welcome to OncoAlert Colloquium Best of Kidney Cancer 2024. My name is Vincent Chu from Dana-Farber Cancer Institute. A lot has happened in kidney cancer in 2024, and we're going to focus on the following items: adjuvant therapy updates, immunotherapy re-challenge in kidney cancer, biomarker updates, clinical updates from reported trials, new drugs, and RCC with divergent histologies. Let's start with adjuvant therapy. We know from prior reports from KEYNOTE-564 that adjuvant pembrolizumab improved disease-free survival compared to placebo and was FDA approved based on this improvement. Now we know from updates to KEYNOTE-564 that overall survival was also improved. This trial enrolled patients for 1 year of adjuvant pembrolizumab compared to placebo. Patients had kidney cancer surgery and had either intermediate high risk, or M1 NED. Overall survival was improved in the intention to treat population from adjuvant pembrolizumab with a hazard ratio of 0.62. This benefit was seen across subgroups. Similarly, updates to disease-free survival continue to show benefit from adjuvant pembrolizumab, and this was also preserved across subgroups of patients. Reassuringly, most patients received subsequent therapies, and in fact, among patients getting subsequent therapy, most patients who initially got placebo eventually got an immunotherapy, which is a reassuring finding. In summary, adjuvant pembrolizumab improves overall survival among eligible patients with clear cell kidney cancer, and this is the current standard of care for adjuvant immunotherapy. We also had data from a negative trial. We already knew from prior reports that CheckMate 914 Part A failed to show disease-free survival benefit for ipilimumab and nivolumab compared to placebo. We now have data from a sister trial, CheckMate 914 Part B. This trial compared patients with adjuvant therapy receiving either ipi-nivo, nivolumab, or placebo. Disease-free survival was not better on either nivolumab or ipi-nivo compared to placebo, meaning the trial did not meet its primary endpoint. This was similar to data that was seen across ipi-nivo in CheckMate 914 Part A, again showing that adjuvant ipi-nivo does not have a role in this disease. Let's move to a summary of the adjuvant immunotherapy trials so far. KEYNOTE-564 is the only positive trial and strongly positive for disease-free survival and overall survival, making this the current standard of care for adjuvant treatment of kidney cancer. It's not entirely clear why the other adjuvant immunotherapy trials did not show benefit, although as we'll see, some of that answer may lie in the biomarkers. Next, let's talk about immunotherapy rechallenge. In patients who have progression on prior immunotherapy, should they receive a different immunotherapy in the second or third line setting? Last year, we had data from CONTACT-3 showing that adding atezolizumab to cabozantinib was no better than cabozantinib alone. This year, we have a similar trial, TiNivo-2. This trial randomized patients who had progression after prior immunotherapy to receive either tivozanib on its own or tivozanib with nivolumab. Unfortunately, the addition of nivolumab did not improve outcomes, and there was no improvement in PFS in the intention to treat population or in the subgroups. Overall survival was also similar between arms. In summary, there was no benefit from adding nivolumab to tivozanib after prior immunotherapy. This is consistent with the prior data from CONTACT-3, and both trials show that single-agent TKI, either cabozantinib or in this case tivozanib, are reasonable options after prior immunotherapy. Next, let's look at some biomarkers. There are currently no minimally invasive biomarkers that are available to guide treatment in kidney cancer, but several interesting ones are being investigated. One of these is KIM-1, kidney injury molecule 1. Dr. Albiges and colleagues looked at circulating levels of KIM-1 in the adjuvant atezolizumab trial. As background, we know that circulating KIM-1, which is an extracellular domain of a transmembrane protein, is a blood-based biomarker with strong data in the pre-diagnostic, adjuvant, and metastatic settings. In this data from IMMotion 10, we saw that patients who had high baseline KIM-1 had higher chance of recurrence, but patients who had high KIM-1 also had apparent benefit from atezolizumab, while patients with low KIM-1 did not have benefit from adjuvant atezolizumab. This is the first biomarker to be predictive in the adjuvant setting, and we eagerly await further data from other trials. Next, I'll combine two metastatic trials and their biomarker analyses. The first is the phase 3 CLEAR trial, which led to approval of lenvatinib plus pembrolizumab. The second is KEYNOTE-426, which investigated axitinib and pembrolizumab. In both trials, biomarker analyses were done looking at PD-L1, tumor mutations, and gene expression changes. First, the investigators asked whether PD-L1 expression can selectively identify which patients need combination immunotherapy versus just sunitinib alone. And the short answer is that all patients seem to benefit from combination immunotherapy, whether they were PD-L1 positive or negative. Similarly, looking at tumor mutations, patients across tumor mutation categories had benefit from combination therapy compared to sunitinib. Looking at transcriptomic changes, several transcriptomic signatures have been described in prior studies. Some of these are correlated with outcomes. For example, angiogenic signatures seem to have better responses to sunitinib, and unsurprisingly, MYC and proliferative signatures seem to do worse on sunitinib. Nonetheless, across the board, looking at transcriptomic biomarkers, patients still did better on combination therapy compared to sunitinib alone. My takeaway from all these biomarkers is that as of 2025 January, we should still be offering combination therapies to all patients and should not be excluding immune combinations based on these biomarkers. Next, we have some really interesting preliminary biomarker data for glycoproteomic biomarkers. This was presented by Dr. Braun at ESMO and is the first time this kind of data has been looked at in a large trial. Glycopeptides and specific subsets of glycopeptides seem to be associated with better response to cabozantinib and nivolumab versus sunitinib. This is really interesting preliminary data, and will need to be validated in other studies. Next, let's look at some updates from important pivotal trials. We know that CheckMate 9ER led to approval of cabozantinib plus nivolumab for first-line treatment. Dr. Manchia presented data showing that treatment-free survival is superior for cabozantinib and nivolumab compared to sunitinib in this trial. This echoes prior data which showed that ipilimumab and nivolumab was also superior in terms of treatment-free survival. Treatment-free survival is an emerging endpoint and important to patients as it reflects time that the patients are alive and also alive free of treatment, which tends to be a significant benefit to quality of life. Similarly, we have updated clinical data from the nivolumab and cabozantinib trial showing that overall survival and progression-free survival continue to favor this combination over sunitinib. The same is true for data from CLEAR for pembrolizumab and lenvatinib, continuing to show PFS and OS benefit. And again, for CheckMate 214, Ipi-Nivo continues to show impressive durable overall survival benefit now about 8 months out, and with a tail of the curve suggesting that many patients are in a lasting remission from combination immunotherapy. To summarize, these data reinforce that today, most patients with metastatic kidney cancer should be receiving immunotherapy combinations in the first-line setting, as recommended by the current NCCN guidelines. Next, let's take a look at some new drugs. We are all familiar with intravenous nivolumab. We had this year data on subcutaneous nivolumab from CheckMate 67T. Subcutaneous nivolumab is a new formulation which was compared to IV nivolumab in a randomized trial. This trial met its co-primary endpoints, including PK, 2 PK endpoints, as well as a key secondary endpoint, which was objective response rate. Both the pharmacokinetics and the objective response rates were non-inferior for subcutaneous versus IV nivolumab. The safety signal was reassuring. There were some injection site reactions, but these were generally well-tolerated and transient. In summary, subcutaneous nivolumab is non-inferior to IV nivolumab, and this is an interesting option now for our patients and has obtained FDA approval as of December 2024. We also had an interestingly new IO-TKI combination. This was anlotinib in combination with bemelsibart. This combination was largely studied in China and is similar to our existing IO-TKI combinations. I suspect that this combination will largely see use in China as opposed to the US or Europe, since we already have several IO-TKI combinations available. We know from prior studies that the microbiome plays an important role in immunotherapy response. Including prior 2 randomized phase 1 trials have shown that a microbiome product, CBM-588, seemed to improve outcomes when added to immunotherapy. We now have a trial showing that among patients receiving axitinib plus pembrolizumab, those patients who were randomized to fecal microbiome transplantation seem to have better outcomes compared to those who got placebo in combination with axi-pembro. Indeed, the primary endpoint of 1-year progression-free survival was better among patients getting the fecal microbiome transplant, and overall response rate was also better. As you can see from the secondary endpoints, PFS and OS are also looking in the right direction. These are intriguing preliminary data from small numbers of patients that still need to be validated in larger studies. Additionally, at the very end of 2023, belzutifan was FDA approved in refractory RCC among clear cell patients based on LITESPARK-005. This year, we have updated data from this study, which led to belzutifan approval. PFS continues to look better for belzutifan versus everolimus. Overall survival was no different, and we now know quality of life appears to be better on belzutifan versus everolimus. So this is an important new option for our clear cell kidney cancer patients who are second and third line and beyond. Next, let's look at patients who have RCC with divergent histologies. We had really interesting data from the SUNY Forecast trial, which was the first randomized trial to investigate ipilimumab plus nivolumab versus standard of care, which was largely single-agent TKI among patients with divergent histologies. Most patients on this trial had either papillary RCC or chromophobe RCC. This trial met its primary endpoint, showing that 12-month overall survival was better for ipi/nivo compared to standard of care. However, it is a little bit interesting that 6-month overall survival, 18-month overall survival, and overall survival across the board were not superior, which means that this study still raises some questions. Nonetheless, this is an encouraging study in these RCC divergent histologies and shows that ipi/nivo is quite a reasonable option. The existing data for other combination therapies is shown in the table below. In summary, what's changed in 2024 for clinical practice? Number one, adjuvant pembrolizumab should be considered in all eligible patients based on overall survival benefit in KEYNOTE-564. Subcutaneous nivolumab is now an FDA-approved alternative to IV nivolumab. Most patients who had disease progression in the metastatic setting on prior checkpoint inhibitors should not be rechallenged with anti-PD-1 or anti-PD-L1 based on now 2 randomized trials. Finally, ipilimumab plus nivolumab is a reasonable treatment option for patients with divergent histology, especially papillary and chromophobe patients based on SUNY Forecast. This trial does still have some questions, and we eagerly look for validation in future studies. I want to mention just some ongoing RCC trials. This is not a comprehensive list, but there's some of the trials that I found interesting. Some of these trials may report in 2025, and some may take a little bit longer. There are 2 adjuvant trials here, one with pembrolizumab in combination with either placebo or an mRNA-based tumor vaccine, and a second trial run through Alliance of tivozanib with pembrolizumab in the adjuvant setting compared to pembrolizumab alone. On the metastatic side, we have several interesting trials. We have triplet combinations of lenvatinib and pembrolizumab combined with either belzutifan or a CTLA-4 inhibitor. We have a new combination immunotherapy, botensilimab and balstilimab versus standard ipi/nivo. We have nivolumab versus ipi/nivo. And we have a trial, Pedigree, which is a 1.5 line trial looking at nivolumab plus cabozantinib versus nivolumab maintenance in patients who got induction ipi/nivo who have neither CR nor progression of disease. Finally, we have a refractory trial, lenvatinib plus belzutifan versus cabozantinib. We eagerly await these further studies. Thank you for your attention, and I'm glad to answer questions in the ongoing discussions and the Q&A.
Good morning. My name is Siki Grissen. I'm a medical oncologist from Switzerland, and I'm going to talk for the Year in Review 2024 for the OncoAlert Colloquium for the topic of prostate cancer. Here are my disclosures. And I will talk shortly about PACE-B, PEACE-1, PEACE-3, PSMA-4, and the APCC 2024 publication. I will start with the PACE-B trial that has been published in the New England Journal of Medicine in 2024 from Nick Van Aas, and it's treating patients with localized disease. And as you see here, almost 1,000 patients were randomized 1-to-1 to conventional radiotherapy, as you see here, for a duration of 4 or 7.5 weeks, or to stereotactic body radiotherapy. And here, the duration of treatment is 1 to 2 weeks, and that's, of course, a big difference for our patient. The primary endpoints were biochemical and clinical failure, and secondary endpoints included quality of life and toxicities. So here the results for the 5-year biochemical control or clinical control, and you see here freedom from biochemical or clinical failure was non-inferior with SBRT versus conventional fractionation. For the toxicity, the CTCAE graded similar grade 2 and more toxicity at 5 years between the two arms. And I don't show you the data, but there were also similar quality of life scores between the two arms. If we move to a later setting, to de novo metastatic hormone sensitive disease, I want to show you the data of adding the radiotherapy in piece 1, so about the radiotherapy arms. And they were reported by Alberto Borsi already in ASCO GU 2023, and we all eagerly awaited the publication. And now the data are published in Lancet 2024. And you see here that local radiotherapy plus intensified systemic therapy improves rPFS in metastatic hormone-sensitive prostate cancer for the low-volume disease patients with minimal added toxicity. When you look at castration resistance-free survival, you see here that the local radiotherapy improves CRPC-free survival in metastatic hormone-sensitive disease, and this for low-volume disease and for the overall population. There was no difference in overall survival. And the authors, and I think it's very important, also looked for serious GU events, and local radiotherapy prevents serious GU events for patients with low volume disease and for the overall study population. If we go to an even later setting, so patients with mCRPC in first line, here is the P3 study that I presented at ESMO 2004, and it's not published yet. This was all patients with bone metastasis and no visceral metastasis. And most of them had ADT alone in the hormone-sensitive setting. Some patients had docetaxel, and very few patients had an RP in the hormone-sensitive setting. The patients were randomized 1-to-1 to receive enzalutamide as the standard of care versus enzalutamide plus 6 cycles of radium-223. The primary endpoint was rPFS by investigator assessment, and secondary endpoints included safety, overall survival, time to next treatment, time to pain progression, and time to first SSC. Importantly, this trial was halted after the publication of the ERA-223 trial, and the use of bone protecting agents was made mandatory. Just to shortly recapitulate again, and I think that's a very important point, only very few patients, as you see here, had abiraterone in the hormone-sensitive setting. 30% had docetaxel in the hormone-sensitive setting. Here, the primary endpoint, rPFS by investigator assessment, that was positive with a hazard ratio of 0.69. And here, the overall survival at the interim analysis with 80% of the events. And again, you see here hazard ratio of 0.69, but you also see a crossing of the curves. So we decided to go for final analysis with 100% of the events. the safety was quite good. So you see here, there was no death due to a drug-related adverse event, and the grade 3 to 5 drug-related adverse events were 19% in the enzalutamide alone arm and 28% in the combination arm. Now, some news for PSMA-4. So again, this is also a patient, the patients also in that trial had metastatic castration-resistant prostate cancer. Patient have to be progressed on a prior RP. And as you know, the lutetium is active in later lines, so after taxanes and after ARPs. And here the question was, how well is lutetium working in the setting before chemotherapy? Importantly, the patients were very well selected. So about 20% had the RP in the hormone-sensitive disease, and patients had to be candidates for a change in RP. And they couldn't be candidates for a PARP inhibitor. So this is a quite selected population because the control arm was an RP change, and we have discussed that a lot. I mean, it's a big question if that is a valid arm, but at least the patients were selected to be candidates for change in RP. And patients were randomized to lutetium, or as I said, the switch of the RP, and crossover was allowed. Primary endpoint was RPFS by blinded independent central review. We have seen the data before, so the RPFS, the primary endpoint, was clearly met. But now we saw at ASCO 2024, presented by Karim Fizazi, the updated overall survival that again didn't show any difference, but quite a lot of patients had the crossover in the RP switch group. And I think this is an important news, again, presented at ASCO 2024. The quality of life was significantly better in the patients treated with lutetium, again, against not a strong comparator. Then a personal highlight, we are doing every second year the Advanced Prostate Cancer Consensus Conference. And in October 2024, we have published the results of the conference from 2024. And this is an open access. So, everyone has really their access to all the questions or the answers of the experts, and also to all the slides with all the voting results. And here you see the panel that we had in 2024. And the next one is already planned for 2026 for people who are interested. And very soon we will also have, within a month, the APCC diagnostics in February 2025. So what is practice changing in 2024? I think really important for our patients with localized disease, with intermediate risk localized prostate cancer, is that SBRT is a new standard of care for these patients that can be used with an optimal disease control and minimal toxicity. For PIS1 in de novo metastatic hormone-sensitive disease, that patients who are treated with a doublet or also a triplet systemic therapy, radiotherapy to the primary may be proposed to decrease the risk of serious GU events and to improve CRPC-free survival and radiographic progression-free survival for the patients with low-volume disease. For PIS3, again, attention, it's not published yet. And of course, also we not approved yet, but the combination of enzalutamide plus radium-223, and very important, plus a bone-protecting agent, may be a potential new first-line mCRPC treatment option for patients with prostate cancer and bone metastasis who have not received a prior androgen receptor pathway inhibitor. For PSMA4, I think importantly, because we have seen the rPFS improvement before, but there was also an improvement in quality of life reported now. And for APCCC 2024, there is open access for all to consult the situations in the management of patients with prostate cancer where we have no strong evidence. So what's coming in 2024, it will be an interesting year again. I'm really looking forward to hopefully see first data from ENSARAD, from the ANSUB group that really does fantastic academic trials in patients with high-risk localized prostate cancer. And the treatment is with radiotherapy plus ADT and enzalutamide. So we will have new data, and definition for high-risk patients is a bit different from the STAMPEDE data, where we know already the results for treatment with radiotherapy plus ADT plus abiraterone. And also, we have already seen a press release. We will see the overall survival data from TALAPRO 2 and trial testing PARP inhibitor plus enzalutamide. And it will be really interesting to see the Kaplan-Meier curves also of all the subgroups. With that, I thank you very much for the attention, and I wish you a wonderful day.
Hello, I'm Dr. Petros Grivas. I'm a medical oncologist in Seattle. I'm a professor at the University of Washington and Ferhat's Cancer Center. I'm very excited to be part of this wonderful initiative by the OncoAlert Colloquium, trying to see what happened in bladder cancer in the last year, 2024. Very exciting developments in the field, huge amount of progress, and I'll try to cover some of the highlights. Of course, it's impossible to cover everything, but I want to at least give you some snippets of what happened in this exciting year, helping our patients with bladder cancer. And I'm going to start my talk, first of all, of course, to give my disclosures, research funding, and consulting. And I'm going to break it down into three different entities. And I will start by localized muscle-invasive bladder cancer. I'm going to talk about a couple of important perioperative or adjuvant clinical trials, the Niagara and Ambassador trials, and of course, put this in context. And then I will continue with metastatic urothelial carcinoma, first-line setting, and of course, subsequent settings. And I'll try to finish with like an overall collection of thoughts I have about this evolving landscape and how I treat advanced urothelial carcinoma today. So I'm going to start with a localized disease setting, and I will focus my discussion, as you see here in this slide, in 1,000 feet view, looking at the different therapy settings and disease spaces in bladder cancer. I'm going to focus specifically in the therapeutic landscape of the neoadjuvant and or adjuvant setting, the perioperative setting, let's say. And I will focus initially, based on my discussion at the ESMO Presidential Symposium, on the very important Niagara trial. And I want to start by pointing out that for years, I would say for at least a couple of decades, neoadjuvant cisplatin-based chemotherapy with gemcitabine cisplatin, or accelerated MVAC, dose-dense MVAC with growth factor support recently, has been the cornerstone of treatment for patients who are cisplatin eligible, fit for cisplatin, and they have localized muscle-invasive bladder cancer with no metastasis, and they're being treated for curative intent localized therapy. These patients who are, again, fit for cisplatin, they go on to receive neoadjuvant cisplatin-based chemotherapy. Usually, we tend to give 4 cycles for node-negative disease. And as I mentioned, unless there's bladder preservation, for some patients, many of them, they undergo radical cystectomy and pelvic lymph node dissection. So the Niagara trial is a very important trial, I think it's a paradigm shifting, I would say, that was presented at the ESMO meeting by Professor Pauls from London. And I had the honor and opportunity to give the discussion in the Presidential Symposium. This was in September 2024. That trial tried to evaluate whether the addition of perioperative checkpoint inhibition with durvalumab, anti-PD-L1, before and after radical cystectomy improve outcomes in terms of event-free survival, overall survival in patients who otherwise would get neoadjuvant cisplatin-based chemotherapy. So as you see in this particular slide, the control group, they got neoadjuvant Gemcis, 4 cycles, and then they get radical cystectomy, and then they go into no treatment observation in the adjuvant phase, shown in black. However, the experimental arm, shown in blue, patients get also durvalumab, anti-PD-L1, which is given in conjunction with Gemcis in the neoadjuvant setting, up to 4 cycles. And then after radical cystectomy, patients get to up to 8 monthly doses of durvalumab in the adjuvant setting. So as I mentioned, this experimental arm has both neoadjuvant and adjuvant durvalumab. And that's important to note because by design, it's impossible to tease out the contribution of the neoadjuvant or adjuvant durvalumab. Here it's a package approach, a sandwich approach, a perioperative approach, as I mentioned. And I will make the point in the next few slides that we cannot tease apart the contribution individually by the neoadjuvant and adjuvant phase. But that's a very reasonable design. This study was designed several years ago, and we knew that historically we had trouble actually accruing in purely adjuvant trials with chemotherapy, conventional chemotherapy back in the day. So this was a huge endeavor. More than 1,000 patients were enrolled, and this is a huge undertaking. I would say an important milestone that this trial fully accrued more than 1,000 patients. So kudos on the investigators, kudos to the people who worked very hard to get this study done. On the left part of the slide, you see the patient population. These are patients who are eligible for cisplatin, and they had muscle-invasive bladder cancer. Most of them had N0, and a very small proportion had a single perivesical lymph node, but the vast majority had the conventional node negatives clinical setting. This trial allowed a small proportion of patients actually did end up having some variant histology subtype component. And as you see, either pure urothelial or a urothelial histology with histology subtype component was allowed. As you see in the slide here, the certification factors on the left lower corner, clinical stage T2 or higher clinical stage, renal function, they went down to 40 ml per minute or higher. That's a little bit different than the conventional GALSI criteria that they use 60 ml per minute for creatinine clearance. Here it's they went down to 40 ml per minute. That's a little bit, I would say, different than what we have seen in previous trials, but at least allows more patients to be considered. And they were certified, patients were certified based on the PD-L1 status. And as I mentioned before, the endpoints here include overall survival and event-free survival. The primary endpoint was event-free survival, and there was an alpha split between event-free survival and pathological complete response rate. Both of them were part of the primary endpoint, and overall survival was a secondary endpoint. Event-free survival was defined as progressive disease after after treatment, precluding radical cystectomy, recurrence or progression after radical cystectomy, and if a patient opted to not have radical cystectomy, this counted as an event, and this was based on FDA guidance. And that's interesting because if we'll see that there was a small proportion of patients who opted to not undergo radical cystectomy, this counted as events. And of course, death from any cause counted as an event as well. I want to go into more detail here about the primary endpoint, pathological complete response. As I mentioned, this is a small part of the primary endpoint. You see on the right part of the slides that the alpha was split, and the majority of the alpha was spent on event-free survival. Only a small part was spent on pathological complete response. And I want to make the point that pathological complete response is a very reasonable endpoint to help go no-go decisions in phase 2 trials. However, it can be impacted by the completeness extent of prior TURBTs, and we do not know yet whether pathological complete response can be a surrogate for event-free or overall survival in the context of neoadjuvant immunotherapy. For all the above reasons, regulatory guidance suggests that pathological complete response cannot be adequate for approval registration for neoadjuvant checkpoint inhibitors. So event-free survival becomes a very relevant, clinically meaningful endpoint in that setting, but of course can be impacted by patient preference. For example, if patients do not undergo radical cystectomy, I mentioned this counts as an event. However, in this particular trial, about 6% of patients, single digit, wanted to avoid radical cystectomy. And this is a small, of course, proportion and seems balanced between the two arms. But in the future, should we think about, should that count as an endpoint if it was a patient choice to forego radical cystectomy? Just food for thought. The other point, of course, is access to adjuvant therapy. And as I mentioned in the previous slide, patients in the control group, neoadjuvant GEM-CIS group, did not undergo adjuvant immunotherapy. And I assume, based on the timeline of the study, the trial was accrued before adjuvant nivolumab was approved by regulatory agencies. So probably the majority, if not all patients in the control treatment arm did not have access or did not receive adjuvant therapy. And I think that's relevant because it can impact event-free survival and overall survival in terms of the proportion of patients in the control arm who undergo adjuvant immunotherapy or did not go, in that case, adjuvant immunotherapy. The additional point is overall survival. It's very relevant, it's important, and can be impacted by access to and the effectiveness of rescue salvage therapies that can be given in the metastatic disease setting in both arms. And this, I think, is important, and I think the investigators are trying to collect subsequent therapies. As we all know, these therapies can impact overall survival, and it's something we need to make an effort across the board to capture those subsequent therapies across trials, not only in this one. This is a slide that I made for my discussion of the Niagara, showing that the pathological complete response rate was increased. I want to focus a little bit on that particular point. There were two different analyses that were done. The initial analysis did not include 59 patients who had available samples based on the incorrect entry of some data points when the analysis was done. So the analysis was repeated, as you see, in April 2024, when those 59 samples were accounted for and considered. And there was a difference, about 10% delta in the pathological complete response rate, favoring durvalumab arm, 37% versus 27% or so with GEM-CIS alone. So that delta of 10%, because it was a redo analysis, reanalysis, the alpha was spent, so there was not technical statistical significant, but there is a difference, as I mentioned, of 10% in the path CR rate favoring the durvalumab arm. And I want to also make the point that because many people are asking, I'm using Dose-Dense-Vac in my clinical practice, and the question is, how do this data impact the use of Dose-Dense-Vac? That's a big question. Having said that, and I think it's an open dialogue and question, we're going to see data in ASCO GU with Dose-Dense-Vac plus pembrolizumab from a small phase 2 trial we did here at UW Ferhats. But overall, I would say GEM-CIS is a reasonable, acceptable, and commonly used control arm regimen. And I think it's acceptable to have it as a control, especially in a big phase 3 trial. And I think the performance of the control group here seems comparable to historical controls like the SWOG 8710 trial in terms of how people did in terms of OS with neoadjuvant GEM-CIS. So I think it's a reasonable control arm. As I mentioned here, the path CR, there was a 10% delta favoring durvalumab arm. I think this is interesting. Is it meaningful? I think it may be meaningful, but I think in my mind, by itself, I think it may not explain fully the significant difference in EFS and OS. I think the adjuvant component also may have significance and may also contribute to the EFS and OS benefit that happened in this particular trial in the durvalumab arm. And I think that's relevant to note because we have the CheckMate 274 and Ambassador trials, both shown significant disease-free survival benefit with adjuvant anti-PD-1. And as I mentioned before, we do not know for sure. We are not fully certain whether the neoadjuvant, adjuvant phases are either or both are needed, and that I think something we can tease out in future trials. But the Niagara took a sandwich approach, as I mentioned, with perioperative durvalumab. The benefit seems incremental in terms of event-free survival. As you see, the hazard ratio event-free survival is 0.68. I will show you in the next slide, which is meaningful. And I think it's clinically meaningful. The OS also is statistically significant and clinically meaningful. If you look at the number needed to treat based on the absolute difference in EFS and OS, it's about 13 or 14 patients to benefit one, but that's clinically meaningful. And I think despite the caveats I mentioned before, I think this practice-changing trial, you see the Kaplan-Meier curves that I will show you in the next slide, separate early and they stay separated, and might be a tail of the curve, talking about patients who are cured, and that tail of the curve seems to be a higher, more patients probably being cured with the durvalumab addition. Of course, as I mentioned, the results can be impacted by access to adjuvant nivolumab that may not have been given in the control arm, and of course by the access and effectiveness of subsequent therapies in metastatic disease in terms of overall survival. As I mentioned, in my opinion, this is practice changing. The design cannot differentiate between the impact of neoadjuvant and or adjuvant components, but I think the Niagara is probably the best data we have so far, and we're awaiting the regulatory approval to see what happens, what the FDA and EMA will decide and other regulatory agencies based on these data sets. This is a schematic I put together for the ESMO discussion. On the left, you see the Niagara data. You see on the left upper corner, event-free survival data, hazard ratio 0.68, and the left lower corner, overall survival data, hazard ratio 0.75, both favoring durvalumab arm. On the right, you see CheckMate 274, a purely adjuvant without neoadjuvant component, adjuvant nivolumab versus placebo, and you see a significant disease-free survival benefit, hazard ratio 0.70 in the intent to treat population. And we saw in 2024 by Matt Galsky and colleagues that interim overall survival analysis favored nivolumab versus placebo in the ITT and the PD-L1 high population. This was published in 2024. I want to put that in your attention. So there is some hint that overall survival may be beneficial with adjuvant nivolumab. Having said that, in the Niagara data, we saw a significant EFS OS benefit and the PathCR difference, I would say, in the first analysis, we saw survival benefit. Putting everything together, I think Niagara, with of course the caveats we discussed, despite those caveats, Niagara data are the best data we have so far. And I personally think I would change my practice based on the Niagara data, awaiting, of course, pending regulatory decisions. And these are ongoing trials. I want to point out on the left upper corner, Niagara was reported. I just showed you the data and my thoughts on it. KEYNOTE-866 with GemCis plus minus Pembro, and of course, the GemCis plus minus Nivo are pending, not reported yet. On the right upper corner, the EV IO trials, the KEYNOTE-B15 in cisplatin eligible patients, and of course the KEYNOTE-905 and the VOLCA trials with EV-IO in cisplatin ineligible patients. In the left lower corner, I want to give a shout out to the ongoing MODERN trial, purely adjuvant setting, 2 randomizations. It's ctDNA positive patients, Nivo alone or Nivo plus relatlimab, the LAG-3 inhibitor, and ctDNA negative patients. We have nivolumab or surveillance to answer 2 questions: whether immunotherapy escalation with doublet versus single agent checkpoint inhibition is warranted or not in the ctDNA positive, and whether we need or not adjuvant Nivo in ctDNA negative patients. These 2 questions hopefully will be answered if MODERN trial accrues. So more to come, and you see design on the left lower corner. As I mentioned, the ctDNA negative population, Nivo versus surveillance, that will be very interesting as well to look at. And in the IMvigor011 trial is ongoing. We have seen some data from Professor Pauls in ctDNA negative patients, but IMvigor011 is trying to answer the question, atezo versus placebo in ctDNA positive patients, building upon the hypothesis generated by the IMvigor010 trial. So more to come. These trials are pending. Results have not reported yet. Take-home message so far, and I will move forward to the next part of the talk. I think here practice-changing data, in my opinion, based on the Niagara data. We have to see about the contribution of in each therapy phases. I think it's interest to look at exploratory analysis in different subs stratified by pathologic states. I think it's compelling and theoretically makes sense to have neoadjuvant therapy in this particular context. We also have lessons learned from other tumor types regarding the importance of neoadjuvant therapy for lung cancer, breast cancer, melanoma, and these have shown that there is benefit with neoadjuvant immunotherapy. Of course, it's hard to compare across tumor types, but I think it can give us some lessons learned about the importance of neoadjuvant immunotherapy in bladder cancer as well. Awaiting, of course, important trials. We want to talk about bladder preservation in the future. Can we potentially cure patients with systemic therapy alone? Of course, the immunotherapy challenge. It's a big question awaiting future trials. And of course, for patient advocates and clinical trials are very important. I want to quickly cover a little bit faster the Ambassador trial. This is adjuvant pembrolizumab, specifically versus observation. This is an important trial mimicking I would say, the IMvigor010 adjuvant atezolizumab versus observation and the CheckMate 274 adjuvant nivo versus placebo. And you see here the design of the study. You see that the eligibility criteria are similar to the other adjuvant trials. This is only adjuvant, no neoadjuvant component. Certification based on neoadjuvant chemo, yes or no, pathologic status and PD-L1 status. And you see that patients were randomized to pembro versus observation. And you see the dual endpoints, disease-free survival, overall survival. You see that those endpoints were dual primary endpoints. And about a third of the patients in the observation arm and 20% of patients in the pembrolizumab arm receive a non-protocol checkpoint inhibitor or withdrew consent, something to keep in mind. This trial was positive. The trial was presented before by Dr. Apollo at ASCO GU, and I think the updated data were shown at ESMO this year. And you see here the importance of the data. Hazard ratio 0.73, disease-free survival that favors pembrolizumab, doubling of the median disease-free survival, approaching 30 months versus 14 months. And you see that the median follow-up was 45 months or so. Again, significant benefit with adjuvant pembro versus observation here as a control arm. The benefit was regardless of PD-L1 expression, and that I think is relevant point because we have this discussion about PD-L1. The FDA approval of adjuvant nivo was regardless of PD-L1. The EMA in Europe approved adjuvant nivo only in PD-L1 positive. So I think this data here inform that dialogue. I think at least in this trial, adjuvant pembro prolonged DFS regardless of PD-L1 expression compared to observation. And this is the summary of Dr. Apollo's presentation at ESMO. This was published at the New England Journal of Medicine by Dr. Apollo and our group. I was honored to be part of that study. And you see the take-home points here in this particular slide. You see that we have still uncertainty about the upper tract disease, and that's one of my personal questions. I think upper tract might enrich some biology that may be a little bit more luminal papillary. We have to discuss more about upper tract in a separate study, and we actually are doing a neoadjuvant and adjuvant trials specifically for upper tract. The pattern of recurrence is, as we expect, lymph node, lung, bone, and liver, the most common site of metastasis for those patients who have a recurrence, and we're waiting to see what will happen based on FDA review of the data. I want to move quickly to the metastatic disease. I will go a little bit faster here. And I want to point out that we have two new therapies that came up to us in the last couple of years. We had already the Javelin Bladder 100 trial data with avelumab switch maintenance after response to stable disease to platinum-based chemotherapy. And based on the Javelin Bladder 100 shown in June 2020 at ASCO annual meeting at that time, we saw the GEMSIS Nivo data, and this is the CheckMate 901 trial shown initially at ESMO 2023 in Madrid at the time, and then we showed some updated data at ASCO GU 2024. This is the study schema on the left, GEMCIS-NIVO versus GEMCIS for statin-eligible patients. I want to point out that only 20% of patients in the chemotherapy alone arm got I would say a maintenance checkpoint inhibition, and of about 40%, if I remember, got checkpoint inhibitor at any point of time, and this may impact the performance of the GC alone group because the trial was designed before the Javelin Bladder 100 results came out. On the right, you see the toxicity profile, nothing unusual. The combination seems to be feasible and toxicity manageable, but we have to think about immune-related adverse events when we give a checkpoint inhibitor. The trial showed a significant DFS and OS, and you see that on the left, you see the OS benefit, hazard ratio 0.78. On the right, you see the disease-free survival, to be specific, progression-free survival difference, hazard ratio 0.72 for PFS, and you see these were both statistically significant. You can argue these are kind of incremental benefits. It's not an impressive difference, but statistically are important, and these are, I think this is a great option for statin-eligible patients, especially in areas of the world where there is no access to EV-pembro that we'll talk about in a second. So important data to look at. And I think there were two relevant points I want to point out as I show you this summary slide. In 2024, we saw some data about patients with complete response or durable responses, and those patients had mainly lymph node only disease. And we know that patients with lymph node only mets do better, live longer compared to patients with visceral metastasis or bone metastasis. So it's not surprising that patients with lymph node only metastasis do better compared to the other metastatic subsets. And this is probably true across the board with EV-pembro or GEMCIS-NIVO or with the Javelin Bladder 100 paradigm. And I think the question here is, do you have a patient population who may potentially stop treatment and be, let's say, without treatment-free interval? And that subset of patients may exist. The question is, which patients are those? We lack predictive biomarkers. And how do you apply this data here in the context of EV-pembro, especially if EV-pembro is available? The other point I will make is that we saw some quality of life data from this study in 2024 that complement our picture for GEMCIS-NIVO. Pembro EV, I just alluded to that. Impressive data. EV302, we saw the data at ESMO 2023 by Professor Pauls, and you see that the study scheme on the left here. On the right, you see toxicity data. We have to be very careful and cautious with toxicity. About 56% of patients may have grade 3 or higher treatment-related adverse events with pembrolizumab and enfortumab, peripheral neuropathy, skin rash, pruritus, alopecia, GI side effects, as I mentioned, rash and pruritus, anorexia, and a little bit less cytopenias. All of those things are something to keep an close eye on with Pembro EV. Hyperglycemia can happen in about 10% of patients and can be life-threatening in about half of them, about 5%. So extra attention. But the data efficacy-wise are very impressive. You see here overall survival data on the left, the PFS data on the right, impressive hazard ratio 0.47 for PFS for OS and 0.45 for PFS, respectively, left and right. And you see that the huge difference, dramatic, I would say, breakthrough difference between the curves. Dr. Gupta shows some data and quality of life, and this quality of life PROs data are supportive of Pembro EV in this population. There are many unanswered questions, I would say, and here I list many of them for your review. I won't list all of them, but I think in the context of the Niagara data, one of the questions is, how can we treat patients with prior exposure to checkpoint inhibition? I think that's a big question, I think, in the field. And of course, the other question is, how can we define EV-ineligible patients? I think we have to be very careful because you do not want to deprive the benefit of EV, in patients who could potentially get it. So I think we have to be thoughtful about that in the future. Who are those patients who are EV ineligible? I do not think we know yet, and I think the vast majority of patients can probably get EV either the standard initial dose or maybe in unique circumstances in starting lower dose. But I think EV-pembro is probably the preferred standard of care regimen in our patients in the frontline setting. And the approval of Pembro EV by FDA does not specify the line of therapy. I will finish with the TROPiCS-04 data, and I think it's important to discuss this data. I had the opportunity to present that at ESMO Asia on December 7, 2024. This is the TROPiCS-04 trial. As you see here, you see that you have patients with metastatic urothelial carcinoma, ECOG PS 0 to 1. This is a patient population heavily pretreated. They had of course, prior platinum-based chemotherapy and checkpoint inhibition. A few patients had prior enfortumab vedotin. Patients were stratified based on the Bellmore score, prior platinum agent, cis or carbo, and the setting in which chemotherapy was given. Randomization was sacituzumab govitecan, 10 milligrams per kilogram, days 1 and 8, every 3-week cycle, versus a physician choice, taxane, single agent, or vinflunine, as you see on a 3-week cycle, and the primary endpoint was overall survival. I want to point out that growth factor support primary prophylaxis was not mandatory, was not required, and I think that was very important to point out. There was an, after IMDMC recommendation, a memorandum was sent out to participating sites in September 2022, strongly recommending primary prophylaxis with growth factor in the beginning of treatment, but as I mentioned, this was not mandatory. And the median follow-up of the data I will show you was about 9 months. Overall survival data shown in this slide, you see that the median overall survival was 10.3 with sacituzumab govitecan, was about 9 months with taxane or vinflunine, and has a ratio 0.86. You see the confidence interval 0.73 to up to 1.02, crossing 1. This was not statistically significant. You see the 1-year overall survival rate, 44% versus 37%, and I want to point out that in the Kaplan-Meier curves, you see in the beginning, you see a little bit deep with the blue line, the sacituzumab, that may reflect some early neutropenia-related deaths that happened in that particular arm. And as I mentioned, growth factor was not mandatory. And then there is a crossing of the Kaplan-Meier curves, and they stay separated until probably the 2-year time point, and then they come together. As I mentioned, there is a numerical difference, but this was not statistically significant. And you see here what I alluded to that before, there was a number of neutropenia-related deaths in the sacituzumab arm, and that I think probably has a major impact on the outcomes because those patients, of course, had an untoward event, and they, of course, count in the primary and secondary endpoints. And I want to underline that in this granular manner. Here is a forest plot. You see that across the board, with very few exceptions, there is a trend towards benefit with sacituzumab govitecan across the different subset of patients. Of course, the confidence intervals can be wide, and most of them cross 1, so there is no significance, but there is at least a non-significant trend favoring sacituzumab in this forest plot. These are the PFS data. Here you see median PFS 4.2 versus 3.6 months, hazard ratio 0.86, crossing 1. This is not statistically significant. Median PFS data you see. And of course, the 1-year PFS rate about 15% with sacituzumab, about 9% with taxane vinflunine, as I mentioned, the trend, but this was not statistically significant. But I want to point out that this was not formally tested because the trial had a hierarchical design. So if the OS was not met, and was not met, there was no formal testing of PFS. So I want to point this out as well. Response rate here 23% with sacituzumab, 14% with taxane or vinflunine. You see the odds ratio 1.84 favoring sacituzumab. The median duration of response 7.2 versus 6.5 months, and the clinical benefit rate you see 30% versus 21%. Again, numerically favoring sacituzumab versus taxane or vinflunine, as you see in that particular slide. And as you see in the lower part of the slides, the highest overall response rate was observed consistent with the prior results of the TROPiCS-01 trial, again, discussing about the activity of the compound. Toxicity is a very important slide. As I mentioned before, 16 events happened with sacituzumab govitecan. There were infections that happened in the setting of neutropenia, of which 14 out of those 16 occurred in the first month of treatment. Again, raising the importance that if someone uses this drug for metastatic urothelial carcinoma, it's very important to use primary prophylaxis with growth factor. The primary prophylaxis with growth factor was very low in the study. It was approximately 20% only primary prophylaxis was used, and this use was associated with lower chance of neutropenia and febrile neutropenia. And you see there that this patient population has very high risk. Senior patients, prior surgery, distorted anatomy, prior chemotherapy, radiotherapy, those risk factors as per ASCO guidelines, again, making the point that growth factor, in my opinion, should be used as primary prophylaxis if sacituzumab is used in metastatic urothelial carcinoma. This is the conclusion slide. As you see, SG did not result in improvement in OS and PFS. As a result, the approval by the FDA, the indication was voluntarily withdrawn by the company a few weeks ago. And as you see here in this particular slide, there are discussions about why the trial did not meet the primary point. Of course, efficacy is one factor. Of course, the toxicity events. A few patients on the control arm were randomized but were not treated. Some of them were censored. Of course, subsequent therapies is also relevant. About 20% of patients got enfortumab vedotin afterwards. That can be an effective therapy and may impact overall survival as well. This is the practice-changing slide. I want to make this summary. We're waiting to see what the FDA, EMA, and other regulatory agencies will decide about durvalumab based on the Niagara data. We're waiting to see what the FDA will do with the Ambassador trial data. We're awaiting several trials, neoadjuvant or perioperative trials, or adjuvant trials in the localized MIBC setting. We're also waiting to see about phase 3 trials in the blood preservation setting with chemoradiation plus minus checkpoint inhibition, so NRG 1806 and Keynote 992 trials. Of course, in the frontline setting, pembro and enfortumab I mentioned, we saw some PRO quality of life data by Dr. Gupta, and we also saw some data by Dr. Petrylak that showed that the initial EV dose in EV monotherapy trials correlates with higher response rates if it's standard dose, but subsequent dose adjustments of EV are okay and do not compromise outcomes, lending support to our practice that it's okay, and we'll let the patients know that it's okay to dose adjust EV, reduce, hold as needed to adjust if toxicities happen based on side effects. Sacituzumab govitecan indication was withdrawn voluntarily based on the data from TROPiCS-04 that I showed you. And I want to also point out trastuzumab deruxtecan has a pan-tumor FDA accelerated approval for IHC 3+ using the gastric cancer scoring algorithm. So make sure you test advanced urothelial cancer for NGS, for FGFR3 alterations for erdafitinib, but also HER2 IHC to look for IHC 3+ based on the gastric cancer scoring system for trastuzumab deruxtecan as an option. This is a slide that I just put together just for your convenience, how I treat personally advanced urothelial carcinoma these days. As I mentioned, preferred first line is pembro and enfortumab. There are other options, and of course, subsequent therapies depend on what happens in first line. Performance status, comorbidities, organ function, toxicity profiles, level of evidence, and multiple other factors influence the choice. Of course, genomics, FGFR3 alterations for activating mutation or fusion for erdafitinib, and of course, the IHC for HER2 for trastuzumab deruxtecan. And as I mentioned, sacituzumab govitecan label was withdrawn a few weeks ago. Clinical trials remain very important and a big priority, and we try to improve upon this huge progress. Thank you so much for allowing me to review all this. I took a lot of time, but there's so much to cover and so much to discuss. We're very excited about 2025 and the years to come for our patients with urothelial carcinoma. Thank you so much for the attention, and thanks to the OncoAlert for this amazing educational mission and all the OncoAlert is doing to help disseminating the information for our community and for the patients. Thank you so much.
Hi, everybody. My name is Sean McBride. I'm a radiation oncologist at Memorial Sloan Kettering Cancer Center in New York. And I'm going to be presenting on what's changed, the best of GU radiotherapy in 2024. So just to move on to our agenda, I think there's 4 notable trials that I want to highlight that have really changed, I think, the standard of care, GU radiotherapy this year. What I try to do is focus on published work. Obviously, there are additional abstracts, I think, that were presented at various meetings that also bear on standards of care, but what we're highlighting here has been published. So we'll start out with Fast Track 2, Dr. Siva's trial, which I think is one of the more important trials that have come along in the last few years, in part because it really introduces SBRT to renal cell cancer. So this was a non-randomized phase 2 trial published in the Lancet Oncology. The participants in the trial had a solitary primary renal cell carcinoma that was judged to be either unresectable or where surgery was unacceptably high risk. And the treatments delivered here were SABR to the primary lesion, either 26 gray times 1 if the lesion's less than 4 centimeters, or 14 gray times 3 to lesions between 4 and 10 centimeters. The primary endpoint was local control, imaging based, as judged by RECIST 1.1. And you can see the secondary endpoints here. Importantly, renal function was looked at. So what are the results? So on the left-hand side of the screen here, you can see that 129 patients were screened for eligibility. 71 were enrolled. One didn't commence SABR, so there were 70 valuable patients. 27 received the 26 gray times 1, and 47 received the 42 gray in 3 fractions. Median follow-up was 43 months. And, what was really impressive here was that there was 100% local control. You can see here over on the right-hand side of the screen, it obviously doesn't get much better than that. And that was really I think the take-home point here. Delivering ablative SABR doses adequately controls renal cell carcinoma at this median follow-up at the 2-year mark, at the 12-month mark, again, 100% local control. Now, importantly, there were slight declines in EGFR at 12 months and at 24 months, but nothing that was judged to be of clinical significance. So I think the take-home point from Fast Track 2 is that for predominantly T1b lesions or larger, SABR offers excellent local control with mild reductions in what I would describe as not clinically significant reductions in renal function. So we're currently offering this as an option to our patients at Sloan Kettering, and I know across the country, at least in the US, this is being widely adopted. Again, we're limiting it to patients who our urologic surgical colleagues view as either unresectable or too high risk. There's also a couple fascinating trials in renal cell coming down the line, especially from NRG and from Alliance, and so we'll look forward to accruing to those. Second trial, PACE-B. Dr. Van Os for the UK group, reporting this out in the New England Journal. This is a phase 3 open label non-inferiority randomized controlled trial. Again, this enrolled low or intermediate risk localized prostate cancer patients. They were randomized to either 3625 or 40 gray to the PPV or to the CPV SBRT dosing versus conventional or moderately hypofractionated dosing. And the primary endpoint was biochemical or clinical failure. So this made quite a big splash. A couple of things I want to point out here up in the top left of our table 1. The vast majority of these patients were intermediate risk patients. Now, there have been some discussion, some commentary that maybe some of these patients would have been better suited for active surveillance. It's probably the distinct minority. Certainly some portion of favorable intermediate risk patients we are enrolling into active surveillance protocols at our institutions. But the vast majority of these patients were unfavorable intermediate risk prostate cancer patients. And for those patients, obviously, the vast majority of us are recommending treatment. So this is a clinically relevant cohort of patients. Another thing I want to point out, these are the couple of variables that we look at when we're trying to ascertain whether a patient is best suited for SBRT or moderate hypofractionated radiation. We look at the prostate size. In this trial, the vast majority of patients had prostates that were less than 80 cubic centimeters. And the vast majority of patients had mild or moderate LUTS. Very few patients with severe LUTS, as judged by an IPSS score or IPS score greater than 20, were enrolled on this trial. So looking at the biochemical control, there was no statistically significant difference in biochemical control or in freedom from commencement of hormone therapy. But what I would note, I think this is important to point out. What's the time frame at which we're seeing these failures? Obviously, it's years out for radio recurrent disease, and I think you can look at these KM graphs and start to see some separation towards the 5 or 6 year mark, especially in the freedom from commencement of hormone therapy. And I would argue that's really the clinically significant. That's the most pertinent endpoint for your patients. Biochemical failure is one thing, but what's the probability that upon failure they're going to they and their physician will reinitiate ADT? And that's the clinically mean. That to me is the more clinically pertinent endpoint. And you can see the curves start to separate there. Now, in terms of toxicity, there is the portion of patients with R2G grade 2 or greater toxicity did start to separate, but at the 2 year, the cumulative incidence of that did start to separate. But ultimately, there was no difference in epic subdomain scores, as you can see here. So the non-inferior tumor control, I would argue maybe a trend towards an improvement in the freedom from commencement of hormone therapy in the SBRT group. There were no differences in MD-reported GI tox or ED, and no differences in epic subdomain in the epic subdomains. There was increased medium term MD-reported GU tox. So for patients with mild to moderate LUTS, SBRT is our standard of care. Again, if patients have a large gland, if patients have severe LUTS, those are the types of patients where we're likely leaning more towards moderate hypofractionated radiation. So that's PACE-B. Next up is this triad of very impressive publications, again out of the UK, for the Radicals HD trial. There were 2 publications in the Lancet looking at the no ADT versus short ADT arm and the short ADT versus long ADT. And there was a publication of the arm of the trial that randomized patients as 1-to-1 randomization, no ADT, short course ADT, or long course ADT. So what is this trial? Again, this is the trial of post-op radiation. So any patient due for RT after RP who was M0 with a PSA less than 5 was eligible. So these included adjuvant and salvage patients. Now, how did this randomization go? So there was this was a dealer's choice, up to the patient and their treating physician. They could either enroll in a 3-way randomization, the 1-to-1 randomization I mentioned, RT alone, RT plus short course hormone therapy, or RT plus long course ADT. Or they had a choice of 2 two-way randomizations. So patients could opt for randomization to no ADT versus short course, or patients could opt for a randomization to short course ADT or long course ADT. What was the ADT? It was short course was 6 months, long course was 24 months, and the teams could use either an LHRH agonist, an LHRH antagonist, or bicalutamide. And you can see, and what was the radiation regimen? It was either a mod hypofractionated regimen or a more conventionally fractionated regimen just for the prostate. The vast majority of patients with prostate bed, but we'll see that in table 1. So this was a huge trial. 2,839 patients joined the Radicals HD trial. 1,150 chose randomization between the short course and no ADT arms. And 1,197 chose 2-way randomization between the short course versus long course, and 492 chose the 3-way randomization. I think these 2-way randomizations were opened up because patients tended to have a preference, a strong preference of whether or not they wanted ADT. And so that really allowed a much more rapid accrual. The primary endpoint here was metastasis-free survival. So I do want to point out some table 1 differences here. So for the short course versus long course, these patients tended to have higher Gleason grade disease at the time of their radical prostatectomy. And that's notable. About a third were Gleason 8 or greater. The other couple of things I would point out, this is from the 3-way randomization arm, but these table 1s are very similar outside of the Gleason score for the short course versus long course across the board. So the majority of these patients were early salvage with a median PSA of 0.2. The majority of these patients got the conventionally fractionated 66 and 33 to the mainly prostate bed. You can see here, 92% of patients were treated at the prostate bed. Now, in the short course versus long course, maybe 80-something% were treated to the prostate bed. But again, regardless of which arm you chose to enroll in, the vast majority prostate bed only radiation. And finally, the ADT of choice here was the GHRH agonist in the vast majority of patients. So what were the differences here? What was the outcome? So this is a table from the publication in European Urology of the three-arm randomization, but I think it nicely summarizes things. So in the two-way randomization, the none versus short, there was no statistically significant difference in metastasis-free survival. Again, that was the primary endpoint. But in the short versus long course two-way randomization, there was a statistically significant difference in metastasis-free survival, again, favoring the longer course versus the shorter course. And here, two tables pulled from, this table was pulled from the short course versus no ADT Lancet publication. And you can see here, the freedom from distant metastases, there was no statistically significant difference. The p-value was 0.24. But again, what I want to point out here, and I don't mean to harp on this, but it's a little bit of a theme to the talk here, is that time to non-protocol ADT, which is a meaningful endpoint. Maybe even more meaningful than metastasis-free survival to an extent, because this is what really impacts patients, or what can really impact patients' quality of life. And you can see here that there was a dramatic difference in the time to non-protocol ADT. In the no ADT arms, or in the proportion of patients at 10 years who were free from ADT. In the no ADT arm, 73% of the patients were free from non-protocol ADT. But in the short course ADT arm, full 82% were free. So a 10% absolute difference. Now, what about the short course versus long course? This is the freedom. Here, it was significant for both freedom from distant metastases and time to non-protocol ADT. So in the freedom from distant metastases at 10 years, 80% were free in the short course arm, 87.6% were free in the long course ADT arm. So a significant difference in favor of the long course ADT. And again, the time to non-protocol ADT. This is the interesting thing. Now here, the absolute difference between the arms was less than the absolute difference between the no ADT versus short course ADT arm. So at 10 years, 68% of the short course ADT patients were free from non-protocol ADT, and the long course arm was 75%. So, a difference of about 7%, but a statistically significant difference nevertheless. So sort of how have we integrated this into our own practice? Well, I think for patients with more favorable risk, early biochemical recurrence, we're favoring short course ADT. For patients with less favorable early biochemical recurrence, if they have, say, PT3 disease plus a Gleason 8, 9, or 10 at the time of RP, and maybe with a more rapid PSADT, we're favoring the longer course ADT. Obviously, there's a bunch of trials that are evaluating the benefits of ARPIs in this higher risk biochemically recurrent cohort, and we're anxiously awaiting those results. The other thing I would note that in our practice, also we have integrated lymph nodes into the treatment here because of in large part because of the support trial showing a biochemical recurrence-free survival benefit. So that's our sort of standard of care, how we sort of triage the early salvage patients. So finally, what about Energy GU003? This is also a very important trial. It's, again, randomized controlled trial, post-prostatectomy salvage RT dosing schedules. And the criteria here were patients either had to have a detectable PSA greater than 0.1, or they did allow adjuvant patients with undetectable PSAs if they had PT3 or positive margin. These patients were randomized to either 66 gray and 66.6 gray and 37 fractions, or 62.5 and 25 fractions. This treatment was just to the prostate bed. What were the endpoints? Well, the endpoints were co-primary endpoints, 2-year changes in epic bowel or urinary subdomains. And the non-inferiority differences in the GU domain had to be less than 5. So the difference between the two arms had to be less than 5 at 2 years in the GU domain, and less than 6 in the urinary domain. So what were the findings here? Well, on the primary endpoints, you can see here in table 2 in the top right, there was no the two arms were judged to be non-inferior. The high port arm, meaning the moderately hyperfractionated arm, the change in the urinary domain was -5, mean change 0.01. In the conventionally fractionated arm, it was -4.07. That difference of 1 between the arms was judged to did not meet the inferiority threshold. You can see that here in the p-value. So non-inferior on the urinary domain and the bowel domain. A little bit of a bigger difference here, but again, not meeting that threshold of a 6%, 6-point difference. So on the primary endpoints of patient-reported epic domain changes in urinary bowel movements in 2 years, the moderately hypofractionated prostate bed treatment was judged to be non-inferior to the conventionally fractionated prostate bed treatment. And on the physician-reported outcomes, the time to first occurrence of grade 3 or higher adverse events, this was not a statistically significant difference. You can see here the march out over time of the urinary and bowel epic subdomains. The one thing I would note, at the end of radiation, the patients in the moderate hypofractionated arm had a greater decline in their bowel scores than the patients in the conventionally fractionated arm, but that difference evaporated on longer follow-up. So for patients with good bowel function, and e.g. patients who don't have irritable bowel syndrome, and good urinary function, we're a little bit conservative at MSK, meaning no yet pad usage, we're comfortable with moderately hypofractionated RT to the prostate bed. We've also tried to integrate the SAC-910 data on dose level, and we've tended to use 60 gray and 25 as opposed to the 62.5 and 25 that the NRG used. The other thing I would point out is, do we treat nodes simultaneously? Yes. Obviously, as noted, as I mentioned in my discussion of the Radicals trial, we do treat nodes in these patients fairly routinely, and 45 and 25 is a conventional dose that nicely integrates with the hypofractionated dose that we're giving to the prostate bed. So those are the 4 trials that I think are important to mention, published in 2024. And I want to thank you all for joining me.
Hello, Declan.
Hello, Renu. How are you?
I'm well. How are you?
So thanks very much to Gil Morgan and everybody at OncoAlert for inviting us here at GUcast to participate in the OncoAlert Colloquium, which looks amazing. We're really looking forward to tuning into many of these sessions ourselves, but we're conscious that not everybody knows us, so we should introduce ourselves. My name is Declan Murphy. I'm a urologist and director of GU Oncology at Peter Mac Cancer Centre here in Melbourne.
And I'm Renu Eapen, also a urologist at the Peter MacCallum Cancer Centre here in Melbourne.
And we run a podcast called GUcast. This is our studio here in Melbourne, our home studio. We've been running for coming up on 5 years, actually. We have a very multidisciplinary GU Oncology podcast, which we've been running since all through just before the pandemic until now. Right. And search GUcast. We're everywhere, and we do really appreciate feedback and subscribers and all that. And we also really appreciate collaborating with people like Gil and everybody at OncoAlert. And we've had some fun times this year.
We have that. It was really a lot of fun, especially the collaborations that we've had with Gil and with OncoAlert. In fact, at APCCC, do you remember, Declan, we had a big podcast love-in between us, OncoAlert, and Euromigos.
That's right.
And, so that was really fun.
We're flashing up a few scenes from that, but down by the beautiful Lake Lugano, we got together with Brian and Tom from GUcast and Gil from OncoAlert and had a big, really good, fun podcast love-in between these big GU Oncology podcasts.
And one thing that Gil and OncoAlert do really well is bring the GU Oncology community together. And this was really very clear in the ESMO 5K fun run that Gil organised early in the morning in Barcelona.
That's right. We got up at 6:30 in the morning to join Gil and 70 or 80 people down in Plaza Catalunya for the 5K fun run. And that was fun putting that on the podcast as well. So you're a beast, Gil, and everybody at OncoAlert. You have such a great community, and we're really thrilled to bring you a little bit of GUcast highlights from 2024, which is what we're going to do for the next few minutes.
Yeah, and I think there've been some fun ones. There've been some controversies and a few spicy GUcast episodes dedicated to these important topics.
So Gil has asked us to highlight 3 contentious topics of interest on GUcast this year. So we've picked out 3 for you, and we might do a couple of honourable mentions as well.
Definitely.
What's up first?
All right, well, first has to be the RP switch. This is the infamous control arm that we've seen in many of the MCRPC trials.
Because, as everybody knows, switching from one RP when you've progressed in CRPC to another RP has minimal clinical benefit, really, doesn't it? So if your control arm is anchored to having RP switch and not having chemotherapy or radioligand therapy, yeah, some people will feel that this might be an unethical control arm. So early in 2024 at ASCO GU, CONTACT-02 read out and the control arm was RP switch. And well-known commentator, Dr. Vinay Prasad from the Plenary podcast, dedicated a podcast to talking about these control arms. And we invited Vinay on GUcast to tell us what he really thought about RP switch as a control arm.
What he really thought.
I mean, the first point is that in a perfectly functioning oncology ecosystem, Cabo and Atezo would be abandoned in prostate cancer. These are both drugs that have failed as single agent drugs. They have low activity. They're not that promising. Combine them together, and not only they're not promising, you have terrible toxicity. So how can you eke out a win with terrible drugs, low activity, not very promising, have failed themselves in randomized controlled trials? We may remember about cabozantinib famously failed after some JCO, early excitement in the JCO in the middle of last decade. You take these 2 drugs, the only way to eke out a benefit, not even on OS, but on PFS, is if you go up against the absolute worst control arm you can think of, which is giving abiraterone to somebody who progressed on enzalutamide. That is absolutely unacceptable. It's the worst option, especially when you can reach for docetaxel or cabazitaxel or, lutetium-177 PSMA, as you can now. I mean, we've known it's substandard for quite some time. I'm going to read you the quote. We wrote a paper on, I call it profoundly bad, the profoundly bad study, and we write the control arm of abiraterone or enzalutamide, presumably which had not been used earlier, is suboptimal since there is substantial cross-resistance between these agents, leading to poor response rates and short PFS. I mean, it's no secret that these drugs don't work when you've exhausted the prior drug. This is well known. Now, why do they get away with it in PROfound, and why have they gotten away with it in other clinical trials, and why do they get away with it in CONTACT-02? The U.S. Food and Drug Administration is allowing the company to use that as a control arm. The real deficiency is the U.S. FDA. They're letting them get away with that control arm. Yeah. None of us in clinical practice would want our own father or mother to get that, or it's not mother, our father to get that drug if they progress.
There you go. Tell us what you really think, Vinay.
Yeah, he doesn't hold back.
He doesn't hold back.
Yeah, so not everybody appreciates Vinay's communication style with that, but it did roll on, and then we moved to APCCC in Lugano. So our colleague Anthony Joshua, eminent GU medical oncologist from Sydney here in Australia, stood up on the floor at the APCCC and told us what he thought about this control arm.
I'm not sure if we have time to answer this, but I was going to bring up this issue about the control arms in some of these clinical trials, which have been brought up by 2 speakers, and there doesn't seem to be a consensus question which has been submitted on whether these are appropriate for our patients, but I would just like to sort of get people's opinion. Silky and I have actually published on this that I consider these RP switch control arms some potentially unethical in the sense that they're not transparent, which is the problem. They're not in the title. The RP switch implications are not in the consent form, and they're not in the protocol, and they're not justified. I think it's a big problem. I think there's going to be a day of reckoning from our patients who are going to say to us, why did you allow me to go on a trial when the control arm was substandard? And the only people that are endorsing this control arm, it appears to be, are the FDA, whose mandate is simply to find something which is vaguely applicable to the US population. It would be far better if the control arms on all these studies were physicians' choice, thereby allowing us to do the best for our patients, not the best for the FDA.
Anthony, can I take that? Can I take that?
Yeah, so it's, that was an incredible thing to watch. And I think as we end 2024, people are more aware of the issue. And I think more and more are uncomfortable about using RP switch as a control arm.
Yeah, I think investigator choice would be a much better control arm and would lead to much less controversy about that. So that's it. That was one of the recurring themes of 2024, RP switch as a control arm. It's a bit of a dog.
Yeah. Okay, so I love this next one. And it's a great example of how a negative trial can still inform and change practice. And this, of course, is the pelvic lymph node dissection in bladder cancer trial. That's a SWOG 1011 trial.
Yeah, and this was an ASCO plenary in 2023, and then the paper came in the New England Journal of Medicine 2024. A really important, very well done, high quality randomized trial of patients undergoing radical cystectomy who were randomized to either have a standard pelvic lymph node dissection or an extended pelvic lymph node dissection. The hypothesis being that there was an oncological benefit from a more extended pelvic lymph node dissection.
And the results were surprising.
Yeah, because there was not just no benefit in doing a more extended lymph node dissection up into the retroperitoneum, but actually a few extra patients were harmed.
Yeah, there was a mortality associated with an extended lymph node dissection. So I think it's been very interesting to see, and I think it's been very practice changing.
So huge kudos to Seth Lerner, everyone from SWOG who was involved in that trial, including Sia Danishmand, who was one of the senior investigators who we had on the podcast just after the ASCO plenary to talk a little bit about this.
So tell us about the differences in the two arms in terms of complication rate and morbidities.
Oh boy, yeah, I think this is one of the most compelling parts about the final conclusion, and we'll get to that in a second. But the complication rates were higher in the extended node dissection. These were graded grade 3, 4, 5 for adverse events, and it seemed like the thromboembolic events were higher in the extended node dissection. The ileus rate was higher. The death rate was even higher in the extended lymph node dissection.
So there we go. If you're feeling tempted in that cystectomy to extend beyond the standard lymph node dissection template, make sure you have a fellow there who stops you.
Stop you. Put a clip across and stop. So a very important practice-changing trial, albeit a negative trial. And finally, Renu, the other one we picked out was a spicy one for the end of the year.
This was a spicy one. And a negative trial, but it was turned around, wasn't it? And I am, of course, talking about the pelvic lymph node dissection in prostate cancer trial from the great team at the MSK.
Yeah, so this is a trial that we've all been very interested and familiar with for a few years. It first read out a couple of years ago in European Urology Oncology, one paper of the year. It's a single-center randomized trial of more than 1,500 patients undergoing radical prostatectomy, randomized to either a standard pelvic lymph node dissection, which involved just the external iliac nodes, or an extended lymph node dissection, which also involved obturator and internal iliac nodes, the primary endpoint being biochemical recurrence, and the hypothesis being a more extended lymph node dissection might lead to better biochemical recurrence rates.
And of course, their primary endpoint initially was biochemical recurrence. And there was no
negative.
difference, and
Exactly.
it was negative. But
with the more extended follow-up this year, they have updated the trial. It's still a negative trial. There's still no difference in biochemical recurrence. But they did do some data dredging and do a lot of extra analysis and looked at another endpoint that wasn't pre-specified, and that was the rate of distant metastases and overall metastases as measured by various types of imaging, not on a specified time point. So you could have metastases by conventional imaging or different types of PET imaging, and the timing of that PET imaging was dictated by various medical oncologists. And yeah, to everyone's surprise, in a negative trial, they showed that
the extended lymph node dissection in prostate cancer did result in fewer distant metastases with a significant p-value.
So go figure. And this is a really cracking podcast. We had Karim Toujer, who led this trial at Memorial on the podcast. He's been on twice talking about it. And he admitted that it is a bit of a head-scratching thing trying to figure this out, but they very much believe that extended node dissection leads to this. Now, we had a lot of questions. There's a lot of questions about this, so please go and have a listen to the podcast. We'll just show you now a few of the short-form videos that we pushed out from the podcast, because at the end of the year, we started doing a lot more TikTok, Instagram Reels out of the podcast, and these are very, very popular. We get thousands and thousands of hits on these. So we'll give you a flavor of that from this particular podcast.
My trial says that it's beyond the fact that a pelvic lymph node dissection is a good staging procedure. A good lymph node dissection, by that I mean an extended pelvic lymph node dissection, has been shown statistically to reduce distant metastases and any metastases.
The difference between the arms is 12 lymph nodes in the standard arm and 14 in the other arm. So is taking out 2 extra lymph nodes, and I think the operative time was 2 minutes. You know, it would be a very health economic effective thing to do if it reduces metastases. Spend 2 minutes and pluck out 2 more lymph nodes. How can that lead to the reduction.
So I can't really explain from these results how we can biologically explain them.
So Renu, he thinks that while, okay, maybe it's leaving some lymph nodes behind that could metastasize, but maybe it's just the statistics.
Yeah, I mean, instead of a biological explanation, which seems a little far-fetched, could this be a statistical phenomenon that we're seeing?
You keep doing more testing, and that's multi-testing. But data dredging or p-hacking is when you do so much testing and you're going away from your primary endpoint until you get to a p-value that's significant, which is what's got this trial all the attention.
Kind of a way of torturing the data.
Plus, in this instance, it's metastases you're measuring, which are measured on an imaging modality that's not pre-specified, and different types of imaging are being used at different time points. And the absolute difference is so small. You're talking about a few patients difference in each arm that it could all be due to chance. It could just be statistical chance here. And I think that's why there's quite a bit of reaction on Twitter to that. My question to you, could this all be just statistical shenanigans? That so much multi-testing has been done, you found a p-value. It makes no clinical sense to many of us that this difference of 2 nodes is leading to this.
So there you go. Even though the authors do conclude that an extended lymph node dissection should be part of every radical prostatectomy that's done, we do encourage a bit more caution than that.
Yeah, I think it would be fair to say this is hypothesis generating. This is still a negative trial, and it will be interesting to see what the guideline community make of this.
Absolutely.
So briefly at the end, Gil has asked us to say what has changed in clinical practice, and we've got 3 points that we wanted to address on this. First of all, pelvic lymph node dissection for bladder cancer, SWOG 1011, a negative trial. But as Renu said earlier, these trials are very important because it shows we should limit ourselves to just a standard pelvic lymph node dissection and not go extended up above the common iliac. So that's very important. It's a practice-changing trial.
The end of extended lymph node dissection in bladder cancer, perhaps.
Should be, for sure.
Should be. But the answer is not so clear for prostate cancer.
That's right, because despite the Memorial Sloan Kettering team enthusiastically concluding that extended pelvic lymph node dissection should be recommended for all patients undergoing radical prostatectomy, I think that the big change we saw in the EAU guidelines this year is the total opposite. Pelvic lymph node dissection is being de-emphasized in the EAU guidelines, and it will be interesting to see what they conclude when they update the guidelines in the next couple of months, but my bet will be on no change. I think pelvic lymph node dissection will continue to be de-emphasized in prostate cancer, especially in PSMA negative patients.
Absolutely. And then Keynote 564, there seems to be a clear role for pembrolizumab in the adjuvant setting for clear cell renal cell carcinoma.
Proper practice-changing study, and we are on a mission to educate ourselves as urologists around the world about exactly which patients will benefit from this, but that was a real highlight.
So that's it.
Yeah, that was fun.
That was fun. And thank you to Gil and OncoAlert for giving us this opportunity.
Yeah, and keep up the great work. We certainly love collaborating with you and all your team and with the great OncoAlert community that you've created around the whole brand, Gil. And we love learning from you and all your colleagues and look forward to seeing you throughout the year this year.
At many of the wonderful conferences in 2025.
For sure. Take care.
Hi everyone, my name is María José Juanfita. I'm medical oncologist currently working in Fundación Instituto Valenciano de Oncología. And in the next 5 minutes, we are going to review the trials that have changed the landscape in 2024 in GU oncology. And the first study I want to mention is the ARNOT trial, a phase 3 study where 669 metastatic hormone-sensitive prostate cancer patients were randomly assigned 2-to-1 to receive darolutamide, 600 milligrams twice daily, or placebo with concomitant ADT. The primary endpoint was radiographic progression-free survival. At the primary cutoff date, doublet showed significantly improved rPFS compared to monotherapy with ADT, with consistent benefits across the subgroups. The overall survival results were still immature. It changed the arsenal of doublets in the hormone-sensitive scenario, but the comparator arm, the primary endpoint, and the lack of consistent data on overall survival have been the major criticisms performed to this study. The second one is the PSMA-4, which is a phase 3 trial in taxane-naive patients with PSMA-positive metastatic castration-resistant prostate cancer who had progressed on a previous ARPI and were randomly allocated 1-to-1 to receive lutetium PSMA every 6 weeks, 6 cycles, or a change of ARPI to abiraterone or enzalutamide. The crossover was allowed after central confirmed radiographic progression, and the primary endpoint was rPFS, which was achieved with a favorable safety profile, and no statistically significant difference in overall survival between both arms. Once again, the main criticism of the study is the comparator arm, allowing hormone sequence, which is not as effective as we would like to be, mainly after CAR trial results were published in 2019. If we move into bladder carcinoma landscape, we need to refer to RETAIN trial, which is a phase 2 non-inferiority single arm, including 70 patients, CT2, T3, and 0M0, which were sequenced for alterations in ATM, RB1, FANG, and ERCC2. The patients received MVAC neoadjuvant chemotherapy, and those who achieved complete pathologic response, GT0 with an identified mutation, were candidates to active surveillance, and the rest were assigned, not randomized, to chemotherapy or cystectomy. The primary endpoint was not achieved, with no differences in rates of MFS, and no statistically significant association between a mutation and MFS, metastasis-free survival, although a trend toward improved overall survival in ERCC2 was seen. The fact is that the importance of the trial is due to that it's one of the first studies trying to select responders in this perioperative setting using a risk-adapted approach to local consolidation. That probably is a trend to be explored in further investigation. The Niagara trial is a phase 3 trial testing perioperative durvalumab plus gemcitabine plus cisplatin, followed by radical cystectomy and 8 cycles of adjuvant durvalumab, compared to cisplatin gemcitabine followed by radical cystectomy in patients who were considered cisplatin eligible with muscle-invasive bladder carcinoma CT2 to CT4 and 0 or 1 M0. The dual primary endpoints were event-free survival and pathological complete response. The event-free survival assessed by blinded central review in the ITT population showed a significant reduction in the hazard of events in the durvalumab arm, and we are talking of a hazard ratio of 0.68. And the pathological complete response was reported in 2 separate analyses. The planned formal one was not statistically significant, as the threshold for significance was a p-value of 0.001, but in the reanalyze, including 59 previous omitted samples, showed nominal statistical significance in favor of the durvalumab arm. The median overall survival was 46.3 months, with a risk death decrease of 25%. The next one I want to mention is the Ambassador trial, which is a study in the same scenario as CheckMate 274, with the difference of the comparator arm, in this case observation and not placebo, but with the same inclusion criteria. We are talking about patients with muscle-invasive bladder carcinoma in 2 situations. One of them is those patients who have residual disease after neoadjuvant chemotherapy. And the other one are those patients who were considered cisplatin ineligible or refused chemotherapy and have PT3 or T4 and X, or PTX and 0 or R positive, and R positive margins. And they were randomized to receive pembrolizumab for a year versus observation. The dual primary endpoints, the co-primary endpoints were DFS, disease-free survival and overall survival among the ITT population, with a median follow-up of 45 months at the time of this interim analysis. The median DFS was 29.6 months with Pembro versus 14.2 months with observation with a hazard ratio of 0.73. Pembro was associated with a statistically significant DFS benefit compared to observation. At the time of the second interim analysis at median follow-up of 40 months, 3-year survival rate in the ITT population was 60.8% in the Pembro arm and 62% in observation arm. But the fact is that only 80% of events have been reached and the efficacy boundary was not crossed. So probably we need further follow-up to know if this trial could be considered positive in terms of overall survival or not, because it's positive in terms of disease-free survival yet. And last but not least, we need to comment the results of the EV302 trial in patients with metastatic urothelial carcinoma who were randomized as first-line treatment to the combination of Pembro and enfortumab vedotin versus or compared to chemotherapy at physician choice cisplatin or carboplatin gemcitabine. The fact is that an addendum was made because Javelin 100 was published. 30.4% of the population received avelumab maintenance, but not all the comparator arm patients, including the comparator arm, received it. Dual primary endpoints were PFS by ICR and OS. And the trial showed a statistically significant and clinically meaningful improvement in terms of progression-free survival and in terms of overall survival, regardless of cisplatin eligibility or PD-L1 expression, metastasis location, visceral, adenopathic. And the fact is that there are data which are coming to revolutionize the landscape of the first-line therapy. But probably in the next years, we are talking about other combination in the same setting. So we need to further comment all these results. So thank you very much for your attention. Have a nice day and looking forward to seeing you in person soon.
Hello everyone, my name is Elena Sevillano. I'm a medical oncologist from the Clara Campal Comprehensive Cancer Center in Madrid, Spain. And on behalf of the WAR Consortium, I am honored to be part of OncoAlert colloquium to present the most significant advances in RCC of the last year. Let me introduce the key role that WAR plays in shaping the future of oncology. The WAR Consortium is a global initiative group dedicated to clinical and translational research with the goal of improving outcomes in GU tumors through innovation and multidisciplinary collaboration. With more than 30 FT projects, WAR focus on precision oncology, clinical trials development, and mentorship programs designed for all professionals involved in GU cancer. So we are pleased to invite you to the WAR Annual Congress that will take place from June 25th to 27th with both in-person and virtual participation option. These events offer a unique opportunity to connect with leading experts and explore the latest breakthrough in GU cancer. So let's get started. I will focus to discuss these 5 important trials of the last year. So I want to start with the Keynote 564 trial that I think, in my opinion, is one of the highlights of the year. This phase 3 trial presented by Dr. Tony Choueiri evaluated the efficacy of adjuvant pembrolizumab versus placebo in patients with high-risk clear cell RCC following nephrectomy. The DFS benefit was sustained with further follow-up, and what is more important is that pembrolizumab demonstrated a statistically significant overall survival benefit with a hazard ratio of 0.62, reducing the risk of death by 38%. Consistent overall survival benefit were seen across key subgroups, including risk category, PD-L1 expression, and sarcomatoid features. So Keynote established pembrolizumab as the first adjuvant therapy with a significant survival benefit in RCC and a new standard of care. So, can we identify subgroup who may benefit from other adjuvant therapy as atezolizumab? So, we have the results of the phase 3 trial Emotion 010 that evaluated the efficacy of adjuvant atezolizumab versus placebo in patients with clear cell RCC. This trial didn't meet its primary endpoint, showing no significant DFS improvement with atezolizumab. However, in this trial, a retrospective proteomic analysis was conducted to identify circulating biomarkers that might predict recurrence at treatment response to atezolizumab. KIM-1 molecule is a kidney injury molecule. One was identified as the most enriched circulating protein in recurrence versus basal samples. High basal levels of kidney injury molecule 1, KIM-1, in serum were associated with poor prognostic in renal cell carcinoma patients, but also with better responses to atezolizumab compared to placebo. So these findings suggest that KIM-1 could serve as a non-invasive biomarker to identify minimal residual disease, predict response to immunotherapy, and monitor for recurrence. So let's continue with the LIGHTSPARK 005 trial. This trial was a phase 3 trial that led the belzutifan FDA approval in advanced pretreated clear cell RCC tumors. Last year, the final analysis of this phase 3 trial that compared belzutifan, that is a first-in-class HIF-2 alpha inhibitor, against everolimus in advanced clear cell RCC patient that was previously treated with a TKI and an IO therapy. What is notable of this trial is that there was a heavily pretreated population with more than 40% of the patients had at least 3 lines of prior therapy. So looking at PFS, the median PFS was 5.6 months in both treatment arms, with belzutifan showing a 25 risk reduction with a hazard ratio of 0.75. But there was no statistically significant OS improvement with a hazard ratio of 0.92 and a p-value of 0.80. Looking at objective response rate, it was at 23% in the belzutifan arm, with durable responses lasting over 19 months. So belzutifan is a relatively well-tolerated regimen, with the exception of some anemia, some fatigue, which can be dose adjusted. So belzutifan is a promising therapeutic option, and additional combinations are underway. So it's just the beginning of the story of HIF alpha inhibition. So another key concept that was explored last year was, what do we do when there is a progression or immunotherapy? How can we rescue this patient? Can we rechallenge with IO therapy? So we know we already have previous data, negative data, from the CONTACT-03 trial that compare atezo plus cabo versus cabozantinib. So the TiNivo-2 trial explored whether nivolumab could enhance the efficacy of tivozanib in patients who had progressed on prior immunotherapy. There was this inequity of dose of tivozanib because initial data suggested that tivozanib with nivolumab might elicit more hypertension. So this was largely a negative trial with no significant PFS advantage and no meaningful overall survival benefit. So this finding suggests that IC rechallenge in advanced RCC does not provide additional benefit. So I want to end up by showing this interesting study that show how gut microbiome plays a crucial role in the immunotherapy response in RCC. This phase 2 TACITO trial is a randomized phase 2 trial that investigated whether fecal microbiota transplantation may enhance response to axitinib plus pembro in metastatic RCC. The primary endpoint was the rate of patients free of progression after 1 year from the randomization. So this trial met its primary endpoint with a 60% of patients in the combination arm free of progression during the first year. So looking at secondary endpoints, PFS and overall survival also favor the combination therapy, with an overall response rate of 50%, 52%, almost fairly superior with the combination therapy. So FMT represents a novel approach to improving immunotherapy responses by modulating the gut microbiome, guaranteeing further investigation in large clinical trials. So to summarize, these trials underscore important progress in RCC. So KEYNOTE-564 trial is the only trial to demonstrate an overall survival benefit in the adjuvant setting, being pembrolizumab the new standard of care for the adjuvant therapy in high-risk patients. KEYN-1 is a promising biomarker showing that can identify minimal residual disease and disease recurrence. So belzutifan remains an important treatment option for refractory CR-RCC, and no benefit from adding immunotherapy to other or retalent to immunotherapy. And the fecal microbiota transplantation showed the potential to enact clinical outcome in treatment-naive patients treated with immunotherapy. So thank you very much for your attention. I will be happy to take any question.
Hi, I'm Brian Lewis, president of KidneyCan, and my journey with kidney cancer began in 2007 when I received a diagnosis of metastatic disease. 18 years later, I'm living with no evidence of disease. And I know how lucky I am, but I also know that not everyone gets this outcome. And too many families are still losing loved ones to kidney cancer. And we owe it to those people and every family that's touched by kidney cancer to continue this fight. KidneyCan was founded by and for patients, people fighting for their own lives and the lives of their loved ones. This deeply personal commitment drives everything that we do. Our focus is on raising awareness, advocating for change, funding critical research, and building connections within the kidney cancer community. Every effort is tied to one goal: accelerating cures. We provide patient education and support in a number of ways. Our Patient Resource Center is a curated hub of knowledge designed to meet patients where they are in their journey, whether you're newly diagnosed, or managing your treatment, or you're living long-term with kidney cancer. Our town halls are held 3 times a year, and they're dynamic, interactive events that connect patients with leading experts. These webinars cover crucial topics like treatment advances, managing side effects, and navigating clinical trials, and they allow patients to connect with other people who have similar experiences. At KidneyCan, we believe in the power of people. We knew kidney cancer research needed more federal funding, so we mobilized our community to address the lack of dollars dedicated specifically to kidney cancer. And several times a year, we hold advocacy days, both in person and virtually, to meet with our U.S. Congress. We've trained patients, caregivers, and doctors to share their stories with lawmakers, making kidney cancer research a national budget priority. These personal connections are powerful, and they make the issue impossible to ignore. Anyone is welcome to be an advocate for our cause. Advocacy might sound intimidating, but it's an incredibly rewarding experience. Whether you join us in person or virtually, we provide all the tools you need to succeed. Sharing your story is the most impactful thing you can do. Here's a quick video to show you what a day of advocacy looks like.
Come with me on a day advocating for kidney cancer research funding on Capitol Hill. My day starts off with an early morning metro ride downtown. I am a grad student living in DC, but most of our advocates are from all across the country. So I meet up with them in their hotel to get our materials and then eat breakfast. And then we're off to Capitol Hill. So I start out in the House office buildings, meeting with some representatives before walking across to the Senate side. So I was able to get this really cool shot of the Capitol building. On the Senate side, I have even more meetings. In them, we are asking for Congress to increase funding to the National Institute of Health and the National Cancer Institute, as well as to specifically allocate $60 million for kidney cancer research, specifically under the DoD's congressionally directed medical research program. Huge shout out to all the reps for meeting with us, as well as to all the amazing advocates who donated their time. It is always an amazing day for advocacy. And then, yeah, take the Metro ride home. Thank you so much.
So in 2016, the dedicated federal funding for kidney cancer research was $0. But through advocacy and relentless effort, we've steadily grown that number to 10 million in 2017, 15 million in 2018, 20 million in 2019, and we doubled to 40 million in 2020, and then 50 million annually from 21 to 24. Again, this is the power of people coming together to fight for cures. At the start of 2025, our cumulative KCRP funding is $285 million over 8 years. The kidney cancer community has a seat at the table in Washington, D.C., and fewer people are dying of kidney cancer this year than last year. It's incredible progress. So what? What happens next? How do these research dollars translate into real outcomes for patients? Let's look at how we're fostering collaboration and innovation amongst researchers. One of our proudest achievements is the Kidney Cancer Research Summit, which we launched in 2019. We spoke to many doctors and researchers in our early years, and they described collaboration and communication between institutions as a real challenge. So we invited the people who received the KCRP funds and the grants to get together and discuss their work. This event unites researchers, both basic and translational and clinical, from around the world to share breakthroughs and foster collaboration and tackle the toughest challenges in kidney cancer research. This past year's summit, held in Boston, was our most successful yet. With a hybrid meeting, we hosted nearly 800 attendees from 51 countries discussing cutting-edge topics. And KCRS has become an annual gathering of the world's leading kidney cancer researchers working together to accelerate cures. None of this happens without the steady support of our grassroots army. Thank you for your time and support, and thank you to Gil and our friends at OncoAlert for the important work that they do to connect the global oncology community. I invite you also to connect with KidneyCan, whether it's accessing our resources, or sharing your story, or joining our advocacy efforts. Together, we're making progress towards cures for kidney cancer.
Thank you for joining us for day one of the colloquium. We invite you to join us again tomorrow as we review the year's highlights in lung cancer with an outstanding faculty. Once again, we extend our heartfelt gratitude to our partners at the European Society of Surgical Oncology, ESGO, MASC, and CEOG, as well to our collaborators. A special thanks to Roche and Pfizer for the support of the OncoAlert Colloquium, and we thank you for joining us today and for being a part of the OncoAlert community.